So, good evening, friends. Welcome to another edition of IMA Haryana Academic Fiesta. And as we know, India is endemic for HIV disease, and there are many new developments in the treatment of HIV. And we have none other than Dr. Neha Gupta, who's MD General Medicine and FNB Infectious Disease. She has done ID fellowship from Hinduja Hospital and ID observership from CMC Vellore and Wayne State, USA. She had been consultant infectious disease at Medanta from 2013 to 2021, and now she is working as senior consultant infectious disease at Fortis Memorial Research Institute FMRI Gurugram. She is founder of NG Swasth ID Clinic at Gurugram. Uh, I would request our State President Dr. MP Jain sir to declare the meeting open and share his pearls of wisdom.
Thank you, Dr. Pawan. Thank you very much. Thank you, Dr. Neha. And one thing apart from her academic excellence and her clinical excellence, Dr. Neha is a very good human being and very good colleague, and she is always helpful to all the doctors. So that is one USP of her, which I really admire. And HIV, we all know this is a very dreaded problem, but there is a lot of new development, and I hope we will get some new insight by Dr. Neha.
Thank you to Dr. Pawan as well as to you, sir, to IMA for giving me this opportunity. I'm extremely honored to be today here on this platform, and I'm grateful for this. And as has been mentioned that India is endemic for HIV infection. There are almost 60,000 new infections happening every year. So it's very important for us clinicians to be abreast with the latest in the field of HIV. And this is what we are going to discuss today. The latest trends in HIV, which are the NextGen Solutions. Hi, I'm Dr. Neha Gupta, Infectious Diseases Specialist, and I'm founder of NG Swastha, which is Infectious Diseases Clinic in Gurugram, and have close to 2 decades of experience in the world's leading institutes. So today my talk is going to have this outline, and I'm going to discuss whether we should be using 2 or 3 drug therapy for controlling the HIV virus, which are the long-acting antiretroviral drugs which we can anticipate in the near future. How do we prevent HIV infection with a post-exposure prophylaxis, and what are the ways for prevention of HIV with the help of pre-exposure prophylaxis? So for our defense or for controlling the HIV infection, what is better? It's 3 drugs or 2 drugs is the first discussion. And I'm a firm believer of this fact that what doesn't kill you makes you stronger. And this is what happens in case of HIV infection. The treatment never kills the virus. It only suppresses the virus. And that is why the treatment is continuous and lifelong. So when we talk about HIV virus replication itself produces mutations. And this is because of the error-prone reverse transcriptase. In HIV infection, there is a very high replication rate and billions of copies are produced and cleared every day. And besides this, there is also a very high mutation rate. So there is almost 1 in 10 to the power of 4 mutation which happens every new genome. So when the virus is multiplying, it can happen that while it is multiplying, it is acquiring a new mutation and it may become resistant. So mutations, they occur spontaneously in the reverse transcriptase as well as the protease genes. And this results in a mixture of viral species, which is like various viral species in the same patient. So what is the aim of antiretroviral therapy? The aim is to have a maximum and durable suppression so that the multiplication is driven down to a very low level so that the generation of new variants is minimized. So when the multiples are reduced, new mutations will also not occur, and we will not result in development of HIV resistant virus. And that is why the combination treatment is needed, which can so that any variant is unlikely to be resistant to all the drugs which is being given. So when we look at the paradigm of the antiretroviral therapy, currently we have these five groups, and out of these, basically we have the currently most commonly used ones are the nucleoside reverse transcriptase inhibitors, which earlier was zidovudine, lamivudine, but over the last few decades, one decade, the TDF, which is tenofovir disoproxyphil fumarate, and TAF-based therapy have become the backbone. We also have, or the most commonly used ones, NRTIs. We have the NNRTIs, which is the non-nucleoside reverse transcriptase inhibitors, which included the nevirapine, which was initiated early with a very low CD4 count, efavirenz, which also was 600 versus 400. But the next generation molecules among the NNRTIs to be looked out for are the rilpivirine and the doravirine. Doravirine, especially, it can still work when there is resistance with K103N, Y181C, and G190A, and it also has lesser drug interactions. So these are the two molecules which are in the pipeline. Among the protease inhibitors, we have been using atazanavir, but now again it's getting limited. And the most commonly used boosted protease inhibitor is the darunavir, which is available at 800 milligrams daily and 600 milligrams twice daily. Among the integrase inhibitors, we have dolutegravir and bictegravir, which are the most common ones which are available to us. Raltegravir, which was earlier available, has phased out because of the low genetic barrier to resistance, high cost, and also interactions with drugs like rifampicin. The other integrase inhibitors which are in the pipeline or we need to watch out for are the eltigravir and the cabotegravir. And we have these entry inhibitors, which is the CCR5 antagonist, maraviroc, and the fusion inhibitors, enfuviritide, which are also promising agents. Now, for optimum suppression, we need three drugs, and two drugs can be used in certain clinical situation, which we are going to discuss. So let's begin with this combination antiretroviral therapy and understand from the basics that initially, it was the backbone of these two NRTIs along with one NNRTI. So earlier we were using TDF, FTC, and efavirenz for a long time as the backbone, but now the integrase inhibitors have become the most common or the backbone of the ART, which is then combined with two NRTIs. And this is the current recommended antiretroviral therapy. Now, three drugs. Three drugs, why? As we can see, it's very akin to the Trishul of Bhagwan Lord Shiva. So triple therapy is like a Trishul, Bhagwan Shankar's instrument of destruction. However, the triple therapy is also associated with complications like the weight gain and the metabolic complications of diabetes, NASH, as well as the dyslipidemia. So, where is the unmet need and where can we use two drug therapy? So, let's discuss this with the help of this patient. This is a 49-year-old female who in April 2023 was detected with HIV, and she was also having COVID-19, had anemia, odynophagia, had CMV esophageal ulcer. Her CD4 count was just 23, and the HIV viral load was close to 3 lakh copies per ml. Her baseline evaluation was negative for other co-infections like the hepatitis B and HCV, and was also negative for the VDRN and TPHA. Past history revealed that she had received antiretroviral therapy, TDF, FTC, and efavirenz for a few months, and then she discontinued it because of the side effects, which included the vertigo. Now, at this point, as we can see here, she presented to us with a CD4 count and viral load, and we started her on TAF, FTC, and DTG. And let's look at the clinical and the virological and the immunological response. So over the next few months, the viral load shows a very good virological response, and the it has declined to 97. And there is also a immunological response with CD4 increasing from 23 to 198. Subsequently, the next 2 months later, again when we perform, the viral load is suppressed and the CD4 count is maintained to 198. The problem is she has now gained 15 kgs, and that's when we have to consider that is there any other option which we can choose for her? So, which is the ART which may be preferred in this lady who's virologically suppressed but is having metabolic side effects on the triple drug therapy of TAF, FTC, DTG? Should we continue this? Or we switch our regime to abacavir, 3TC and DTG, or go ahead with TDF, FTC with TTG, change the TAF to TDF, or switch to a two drug therapy. So how do we decide on this? So let's take it one by one. Now this patient is having metabolic side effects. Coming to abacavir, 3TC and DTG, it is like the metabolic side effects are attributed to the tenofovir alafenamide, that is the TAF, and that is why perhaps taking out TAF or switching this TAF would be an option. We can consider giving abacavir, where DTG obviously will be the backbone. However, here again, HLA B5701 hypersensitivity test has to be performed, and if it is negative, then we can go for abacavir. The other option is TDF, FTC, and DTG, where TDF, as we now know, also has this weight suppressive effect, but the side effects related to kidney dysfunction, that is renal toxicity, as well as the bone demineralization, are associated with the TDF. So that will be the side effects. And in this lady who's post-menopausal, these two can be very significant side effects. So can we switch to her to a two drug therapy, which has been also studied on the basis of various clinical trials, that two drug therapy of DTG and 3TC can be given in patients, and that has been associated and that is not inferior to the three drug therapy. So we started this patient on the two drug therapy, and let's see what happens. This was in September 2023. Now we repeated her viral load in November, that is 3 months later, and look at this. What has happened to the viral load? The viral load has jumped from 34 to almost 26,730. What has happened? Where have we gone wrong? So when we realized, we went back to the history. This patient had received TDF FTC efavirenz for a few months, and she was not very adherent because she was having the efavirenz related neurotoxicity with vertigo. And hence, because of this, the patient probably had acquired mutations to the NNRTI efavirenz as well as to the FTC, that is the FTC, which will be M184V mutation. And these two drugs are usually the drugs which acquire the mutations earlier whenever there is interruption in the adherence of the regime. So here we performed the genotype resistance testing, and in this patient we started on darunavir, DTG and 3TC after sending the test, because the result of the test will take a month to arrive. But based on our clinical experience and the likelihood of the resistant mutations, we started this patient on a combination of boosted darunavir 600 BD along with dolutegravir. And subsequently, when the results arrived, what does it show us? It shows that there is NRTI resistant mutations, which are K65R as well as M184MV mutation, which confers high level resistance to lamivudine as well as the other drugs, as we can see here. So this patient was on emtricitabine, which the mutations are already present. She was resistant um, to the FTC. Similarly, the K65R also confers resistance to the tenofovir, which is the TDF. So there is already resistance to the NRTIs, that is the nucleoside reverse transcriptase inhibitors. Coming to the NNRTI, this patient was on there is because earlier she had received efavirenz, so there is this Y181C and K101E mutation. All these mutations, the G190A mutation, which are present, that confers high level resistance to the efavirenz. And coming to DTG, the integrase inhibitors were susceptible. So there was no mutation to the DTG. And as she was PI naive, there is no mutation present to the darunavir as boosted darunavir as well. So this patient was on DTG and was on TDF FTC, but since there was resistance to the TDF FTC, and then subsequently when we switched to the two drug therapy, which included DTG and lamivudine, as there was high level resistance to the lamivudine, there was a virological rebound on the dolutegravir. So this was the only drug which was which to virus was like it was the only drug which was susceptible and the virus was exposed to this one. So that's why there was a virological rebound or the virological failure. So although the clinical trials they tell us that there is not much of failure with the two drug regime, in reality in the real world the switch to two drug regime is associated with virological failure, and this was this in this observational analysis. It was found that when they are adjusting it, the virological failure is higher with the two drug as compared to the three drug, and this is influenced by the adherence as well as other factors, especially the previous exposure to the antiretroviral drugs and presence of resistant mutations. So the whole summary of this is that there is a difference in the trial results from the real world experience and results, where there is an erosion in the efficacy of the two drugs versus the three drugs. And of course, as an ID physician, I think we really have to have a very healthy respect for the ability of the organism to acquire resistance. And we definitely do not want to give drugs in suboptimal doses and allow them to acquire or develop resistance. So the current guidelines, the DHS as well as the IAS USA guidelines, they recommend bictegravir TAF FTC combination as the preferred regime. The other preferred regime is the abacavir DTG with the two NRTIs, which is 3TC and abacavir. DTG with FTC with TAF or TDF is also the preferred regime, but in this order. And the two drug regime of DTG and 3TC is can also be considered, but remember, it should be considered for individuals except when the baseline HIV RNA is more than 5 lakh copies, there is presence of hepatitis B infection, and in whom the HIV genotype resistance testing um, has been performed and does not show any resistant mutations. Only in these patients we can choose the two drug therapy. So practically, it has to be the three drug therapy for most of the patients, and in selected patients we can choose the two drug therapy. And the three drug regime definitely it is basically a regime which is good and will maintain a virological suppression is the winner from the public health perspective, where it may be difficult to screen and give a lot of time to individual patient from the private sector, and sometimes where individualized therapy can be offered. The individualized two drug therapy can be offered to patients where there is intolerance or metabolic side effects, HIV primary genotype resistance testing has been performed, and there is no resistant mutations. There is no TB, pregnancy, or hepatitis B co-infection. Another area where I think we should really have three drug therapy is patients with hand. And most of the patients, like HIV patients, they come with movement disorder as well. And in patients with HIV, the HIV associated neurological disorder is basically like here, what happens is the HIV may continue to replicate in the anatomical sites, including the CNS, lymphoid tissue, and the genital tissue, where the antiretroviral therapy may have a different concentration as compared to the other systemic compartments. However, the two drug therapy has also been studied, and in this DOLAM study, they found that the two drug therapy was able to have a lower suppression, like maintain the virological suppression both in the plasma as well as in the CSF at 48 weeks. So it's important to remember that, many guidelines in the Europe as well as in the North America, they have incorporated the two drug regimes. So wherever a individualized approach can be offered, two drug regimes can be adapted. However, the WHO has still not incorporated them because of this primary reason. And of course, two drug regime is also not really offered for the pediatric HIV people as well. So I think as of now, three drugs, but definitely two drugs in the selected situations should be definitely considered. Now we move on to the other next in solution and the latest trend in HIV, which is the long-acting antiretroviral drugs. Now, this is a 33-year-old individual, a patient who was diagnosed with HIV in 2015, and he was taking TDF, FTC, and raltegravir. In 2019, he was switched to TAF, FTC, and DTG. He is virologically suppressed, but he started having dyslipidemia, cholesterol related problems, and that's when in 2021 he was switched to the abacavir after the HLA-B57 abacavir hypersensitivity was negative. On this, also, this patient has been virologically suppressed, but every time he arrives to my OPD, he is asking, when am I going to get the cure for HIV? And when are the long acting antiretroviral drugs arriving? The problem is that people living with HIV have a pill fatigue, and this is the unmet need in the HIV paradigm, that they are really looking out for long term antiretroviral therapy and where they can just take the injections and they don't have to take the daily pill. There are challenges related to the pill burden, drug interactions, adherence, and of course, the stigma which is associated. So, why do we need long acting antiretroviral therapy in HIV infection treatment? It is because of the biological, social, as well as the psychological need. That is, they do not want to be reminded of the of their HIV status, and of course, anxiety and depression is associated whenever with the daily therapy of the HIV or the ART. In fact, this was a survey which was done almost a decade back, that the long lasting treatment with less frequent dosing is a priority for people living with HIV at the almost the most common priority which they are looking out for. So, which are these long acting antiretroviral drugs? The long acting antiretroviral drugs include the rilpivirine and the cabotegravir. And cabotegravir belongs to the integrase inhibitors, like we have the DTG and the bictegravir. And rilpivirine, it belongs to the NNRTI. So, after the efavirenz, we have rilpivirine and the doravirine, and rilpivirine is available as an injection formulation. These two are available as nanocrystals, and they are then suspended in liquid as nanosuspension, and they are then subsequently given as an intramuscular injection form. Initial studies were performed with monthly intramuscular injections, and the studies showed that concentration of cabotegravir as well as in the rilpivirine in the plasma was above the IC90 by almost a factor of 2.3. So they both achieved, the intramuscular injections achieved good concentration in the plasma, which was effective for the virological suppression. There have been trials related to the long acting in ART, that is long acting monthly cabotegravir and rilpivirine as long acting maintenance ART therapy in this latte 2 trial, which was a multi-center open label study. And here in the induction phase, it was the abacavir, lamivudine, and cabotegravir 30 milligrams once daily was given. And once the patient was virologically suppressed, the patients were then randomized into three groups where intramuscular cabotegravir, intramuscular rilpivirine was given monthly, intramuscular cabotegravir and intramuscular rilpivirine in the higher doses was given every 2 months, and the oral therapy was continued. And what does the result show us related to the efficacy? So the intramuscular cabotegravir and the rilpivirine, which was given monthly, or the intramuscular cabotegravir and the rilpivirine, which is given every 2 months, when compared with the oral therapy, was found to be non-inferior. So the virological efficacy and the success rate was similar in the intramuscular long-acting groups. It was similarly efficacious as compared to the daily oral therapy. As far as the side effects are concerned, there were some local injection site reactions associated with some pain, swelling, and the nodules, but not so significant reactions or side effects either. There have been subsequent trials related to the long acting drugs, and this is the Atlas trial, which was published in NAGM in 2020. The phase 3 antiretroviral therapy, long acting suppression trial, the Atlas trial, which here again, the long-acting cabotegravir and rilpivirine was compared with the current oral therapy, and monthly injections were given, and the virological efficacy was not different. So this was not found to be inferior to the current oral therapy. Now, 83% of the patients here did have or did report some injection site reactions. So, efficacy wise, the long acting drugs are efficacious. The question is whether the patients are going to tolerate the side effects, or the side effects are going to be more significant. Similarly, there was this another study which was related to, which was the FLAIR study, which also compared the long-acting intramuscular cabotegravir and rilpivirine, which was given every every 4 weeks, and it was compared with the oral antiretroviral therapy. In the FLAIR study, it was compared with the ABC, DTG, and 3TC. So basically, this was compared, and they found that the virological success of the long-acting drugs was very similar to the combination of DTG, ABC, and 3TC regime. That is the daily therapy. Now, the question is, can we start these drugs upfront? No, the long-acting drugs have to be given only as a maintenance therapy. So they are basically used as a switch. So initially, we start the patient on the three-drug therapy, and then once the patient is virologically suppressed, which is usually for 3 to 6 months, that's when we can switch them to the maintenance therapy. There was this another study, which was this Atlas 2M study, which was also studied, and that compared the long-acting cabotegravir and rilpivirine, which was given 8 weekly with the 4 weekly regime, and they found that whether you give it monthly or you give it at 2 months, both of them have a similar virological success rate or suppression of the virus. Now, as it in the earlier studies, 83% of the patients or very high rates of injection site reactions were noticed. The question among the clinicians has been that whether the patient are going to be satisfied with the long-acting drugs or not. So that is why this has been addressed with the SOLAR clinical trial, which was to assess the treatment satisfaction with the long-acting cabotegravir and the rilpivirine. This is a multi-center randomized open-level non-inferiority study, and it showed that there was a patient satisfaction to the tune of almost 90%. So 90% of the patients accepted and they wanted the long acting drugs. Similarly, in this Beyond study, they found that most of the patients, like with the daily therapy, they were close to 20% of the patients who were being reminded of their HIV status. But with the long acting drugs, this almost 20% just reduced to 1%. They were not reminded of their HIV status and they didn't feel stigmatized either. So that stigma of HIV can be definitely taken away with the long acting drugs. Now, when we give the long acting drugs, when can they fail? So, the factors which may contribute to the risk of treatment failure with the long acting intramuscular cabotegravir and the rilpivirine includes if there are previous resistant mutations to either rilpivirine or to cabotegravir, as the integrase have higher genetic barrier to resistance, usually mutation does not occur to them. But NNRTIs, they have a low genetic barrier to resistance. So usually there are mutations related to rilpivirine. So if there are rilpivirine baseline mutations already present, then there are higher chances of failure. Similarly, if there is a baseline HIV subtype A6 or A1, or if the BMI is more than 30, that's when there is a risk of failure of the long acting drugs. And why BMI? Because that may impact the concentration of the drug into the plasma. So if there are two confounding factors, that will result in risk of failure. So the virological failure obviously is associated with rilpivirine mutations, which includes this E138A and the E138K mutations, which reduces the susceptibility or the action of rilpivirine. So currently, the recommendation or the approved use of the long-acting cabotegravir and rilpivirine is when the patient is virologically suppressed on an oral regime for at least 3 to 6 months and is ready to have a regular follow-up with the healthcare personnel and also ready for the frequent clinical visits because it can be given only as injections. The contraindication includes prior INSTI or a NRTI, NNRTI resistance, and that is why the genotype resistance testing becomes very, very important. Any virological failure and presence of chronic HPV infection are also the contraindications for giving the long acting drugs. This is the prescribing information or as per the FDA and the EMA. Now, coming to the PEP as well as the pre exposure prophylaxis. PEP stands for the post exposure prophylaxis, and this can be occupational and the non occupational post exposure prophylaxis. And there has been an evolution in the post exposure prophylaxis. Initially, we started off only with a single drug therapy, which resulted in a rapid, very significant reduction of 81% in the various case control studies. Initially, we had categories, the low risk and the high risk categories, but slowly this has been erased, evolved, and the new guidelines, which are almost now almost a decade back, there are no categories, and PEP is recommended for all exposures. It's three drugs for as a post-exposure prophylaxis, which is given as a single pill, and of course, these drugs are less toxic drugs. There has to be a baseline evaluation following every exposure, which includes that of the viral markers as well as the VDRL TPHA and the tests which have to be performed. Now, when we look at the HIV test, earlier the first generation and the third generation had a longer window period, but subsequently now we have the fourth generation test, which includes the PE24 antigen, which has a 15 days. So the window period is only 15 days. So initially at baseline, we may do we may do the test, but if there is cost constraint that we may, and if the patient says that, yes, I have not been exposed earlier, then at baseline, we may not do it, but do it after 15 days so that we can pick up the virus. The risk of HIV transmission depends upon the kind of exposure as well. Needle stick injuries, blood transfusion have a higher risk, whereas based on what kind of sexual exposure has happened, the risk of transmission may vary from 0.1 to 3%. Now, this is a young intern who gets an accidental needle stick injury from a seropositive patient, what will be the preferred occupational PEP? TDF-FTC efavirenz, TDF-FTC DTG, TDF-FTC boosted darunafir, or we need more information? So the correct answer is that we need more information. And whenever there's an exposure, please try to find out the status of the partner or the status of the patient. And is the patient receiving drugs or not? So when we inquired, this patient was taking the drugs TDF-FTC and atazanavir for almost a year. And even on this therapy, the viral load was 1,50,000, which means that the patient was having virological failure on TDF-FTC and boosted atazanavir, which indicates that there are resistant mutations to the NRTI as well as to the PI, and that changes the post exposure prophylaxis. And here in this patient, that is why we will give boosted darunavir as well as DTG to cover the resistant mutations of the virus. Now, when we talk about efavirenz as a PEP, it should not be considered for PEP in healthy individuals because it has neuropsychiatric side effects. So, NNRTIs, including nevirapine, or efavirenz, should not be given. Currently, we give integrase inhibitors with two NRTIs, so it's TDF-FTC with DTG or TDF-FTC with bictegravir, which can be used as a PEP and should be started within 72 hours for 28 days. And it's very important to take a good clinical history. This is a patient who had come with repeated unprotected sexual exposures. And in this patient, this was the PEP which was advised, which was duovir, which is lamivudine, sidivudine once daily, and ritonavir 50 milligrams once daily. And then he was requested to see us. So what we did in this patient was, as he had already purchased the duovir, we modified the doses of lamivudine and zidovudine to twice daily and gave him an additional DTG so that there will be three drugs for the PEP. Now, do we stop here or can we offer him some more protection? And as there is similar incidence of unprotected sexual exposure even in the past, there is a pre-exposure prophylaxis which can be offered to the patients. So we have the prevention of HIV has evolved from post-exposure to pre-exposure prophylaxis. And in fact, it can reduce the HIV transmission by almost 30%. There have been reduction of new infections by 30% with the pre-exposure prophylaxis. It still has to pick up in our country. And who should be recommended? It's usually individuals with MSM, heterosexual women and men, or injection drug users who have to be made aware about the pre-exposure prophylaxis. It has to be taken every day. And in case if it is uh, given for receptive anal sex, then it is for 7 days. However, for receptive vaginal sex, then it achieves the maximum therapeutic levels by day 21. There are several clinical trials which have shown efficacy of PrEP in MSM, heterosexual men and women, as well as the injection drug users, which includes the IPREX trial, as well as the partner study. And here the success rate has been close to 86 and the 75, close to 75%. But it's important to remember that even in the IPREX study, the adherence to the pre-exposure prophylaxis, the daily therapy was just 50%. And with 50%, the success rate drastically reduces to 42%. And that is why, because of this problem of adherence to the daily regime, there is also a concept of giving an on-demand exposure, which is given two tablets 2 to 24 hours before the exposure, then one tablet's 24 hours later, and then another tablet 48 hours after the first intake. However, although the on-demand PrEP also reduces, as you can see, the cumulative probability of HIV seropositivity reduces with the TDF-FTC pre-exposure prophylaxis. But this is effective when the number of pills are at least 15 pills a month. And that is why there is a need for a long lasting drugs which can provide or which can improve the adherence. There has also been approval of TAF FTC as pre-exposure prophylaxis, and there are the drugs which can improve adherence and are being studied and probably will be available to us for long acting HIV prevention are the intravaginal ring, which is a polymer ring which releases the drug into the vagina. Then we have this implants, which is the islatravir. These are the devices which are implanted in the body and it releases the antiretroviral drug over time. And the injectable drugs. I'm sure all of us must have heard about lenacapavir, which is a subcutaneous injection to be given every 6 months and it's injected into the body. So just every 6 months, and the patient can prevent themselves from getting the HIV infection, and the antibodies which can be infused or injected into the body for the HIV prevention. So the future is bright, and there are these next-gen solutions, and these are the latest trends in the HIV infection. And I'm open to questions as well. Thank you so much.
Thank you, Dr. Neha, for a wonderful talk. It was very elaborative and very descriptive talk. So, if anybody has any questions, then they can unmute themselves and ask directly with Dr. Neha Gupta.
I think
There
we have
is
a
there
couple
is
of.
one
Can you
question in the
tell
chat
me about
box.
maintenance therapy?
Yeah, yeah.
Okay, so see, it's like so when you talk about maintenance therapy, the maintenance therapy in HIV is the therapy which is maintaining the virological suppression. So if you are on, you have been started on three drug therapy, which is available nowadays as a single drug, and and the patient is tolerating that medicine, then that medicine can be continued. If then we need to have follow-ups related to the side effects of the medicine as well as the virological response. If the patient is tolerating the medicine, then the medicine can be continued until we have some new drug which is better as compared to that medicine. So that's the maintenance therapy. When we're talking about long-acting drugs, then of course there is an initial therapy which is given for induction. Once there is virological suppression, that's when later, once we have the long acting drugs available, we can switch the patient from the oral daily therapy to the injectable drugs, which can be taken every 2 months or probably even every 6 months.
There is another question, ma'am. Will there be any long-term
Long term
side
side
effects which
effects.
we can take care with TLD medication?
Yeah, so when a patient is on TLD, which is TLD here is the tenofovir disoproxil fumarate and lamivudine and DTG. Now, DTG is an integrase inhibitor, and that's associated with side effects related to the weight gain, diabetes, and cholesterol. So these are the metabolic side effects which occur. So we have to monitor for the weight gain. So in my experience, I have seen that younger patients, like less than 50, who are able to work out, control their diet, they can still maintain their weight. They don't really put on weight. But if the patient is a little on like age wise, then they really tend to put on a lot of weight. And especially the side effects, metabolic side effects of DTG are more pronounced when the patient is on TAF. In the in the TLD combination, it is not TAF, it is TDF. And TDF is associated with renal toxicity. So we need to monitor creatinine and also bone toxicity or the bone demineralization. So that's why we need to do a regular DEXA scan to check that there is any osteopenia or not.
There is one question regarding perinatal HIV prophylaxis for newborn.
So for perinatal HIV prophylaxis, the most important is that the parents have to be virologically suppressed. So first is testing. Testing when when people are getting married or testing, that's very important. And every woman before pregnancy needs to get tested. If starting the treatment ART as early as possible, making the lady virologically suppressed, or if the husband is positive, the husband has to be virologically suppressed so that the transmission to the wife may not occur. In case husband and wife both are positive, then both have to be virologically suppressed so that the transmission to the baby does not occur. In case the wife is negative and husband is positive, the wife is negative, then the baby is going to be negative. There is no need to give any prophylaxis to the baby. But if the mother is positive and virologically suppressed, then once the baby is delivered, which can be even a normal vaginal delivery, but the baby has to be given um, has to be given like after the birth, nevirapine. Nevirapine is given for 6 weeks. Syrup nevirapine is available that is offered to the child for prevention of HIV infection.
Dr. Mayank has asked about the thrombocytopenia side effect of uh, tenofovir, dolu, and lamivudine combination.
No, the TLD, that is the TDF, lamivudine, and DTG are not associated with thrombocytopenia. But thrombocytopenia can be the impact of HIV per se. In fact, ITP or thrombocyte, any patient who's having platelets, low platelet count, they should be screened for HIV infection. So that can be the effect or the impact of HIV virus, not the drugs.
And what about sleeplessness with HIV medication?
Yeah, I think this is a very important question. So, sleeplessness can occur with HIV medications. The earlier medications, which like efavirenz-based medicine, especially, many patients still like they are not aware that they're not getting the sleep because of efavirenz. So, efavirenz can result in this. Currently, the medications, the insti-based regimes, the DTG and the bictegravir, they are associated with lesser neuropsychiatric side effects. However, if in case someone is not tolerating, they can start taking these medications in the morning, and that will reduce the side effects as well. One more
And
query, if a patient is virologically suppressed, will he or she
longevity.
live long for 60 years? Yes, yes. So the studies have shown that people living with HIV can still live a life like any other person who does not have HIV infection. The life expectancy with HIV is similar as a person who does not have HIV. So both with it, but that is with effective antiretroviral therapy and regular follow-ups with the healthcare provider or the infectious diseases specialist. No, Virade
VRDB,
cannot be taken in the morning. No, it should not be taken because Virade actually results in a lot of dreams and side effects related to the brain. So it should not be taken in the morning. It should be only taken during the night before sleep.
thank you, Dr. Neha, and thank you everybody. Signing off.
Thank you, Dr. Pawan. It's been
Thank
a
you, ma'am.
pleasure. Yeah, and it's an honor for me. Thank you so
Thank you,
much.
ma'am. Thank you. Thank you.